This is lecture one. We're going to talk about these three topics. Cardiac risk assessment is the big one. That will take the bulk of this lecture. The tiniest sliver of this lecture is going to be the interactions between the clinician or the practitioner and the patient or client or subject. I'm just going to hint at that. And then the final topic is licensure versus certification. We're going to go in the inverse order. So we'll begin with licensure versus certification. And there is a difference, and that difference does matter. I'm going to address this from the perspective of personal training, and that will lead us into the other two topics. So let's start with license. This is a government issued hall pass, basically. It grants you permission to do something you otherwise wouldn't be allowed to do. You'd be prohibited from doing it if you didn't have that license. So think like a driver's license. Or if you want to work in transportation, you need a commercial driver's license, a very specific one. Otherwise, you can't do that. It's illegal. If you want to practice medicine or physical therapy, you need a license for that. The government oversees it. Participation is prohibited if you don't have that license. Now, a certification is a private company. This isn't government. This is a private company's certifying statement that you're pretty good at something, right? You have passable expertise, according to them. So it informs us customers who are outside of the industry that we can trust this person's skills or their judgment or whatever. The certifying body stamps their company's logo on that person's back. So if I write you a letter of recommendation, for example, to get into graduate school, or maybe you're applying for a job, I'm signing my name to you. It's kind of the same thing. And then hypothetically, very hypothetically, if you then perform terribly in graduate school or in the workforce, it makes me look bad. And the same is true with a certification. The certifying agency is not represented in a positive way if the people they certified are helpless, right, or in like all things but criminality. So there are lots of different certifying agencies. I got ACE certified when I was maybe 19, something like that. ACSM is the best. CSCS is outstanding. That one's very, very good. But there are a lot more. This is a tiny fraction of the entire roster of certifying organizations for personal training and health, right? And looking at sort of health in that regard. But notice that most of them are for profit. It doesn't mean for profit is corrupt and bad and terrible, but we look more favorably on the nonprofits, and most of them are not that. And if you do an internet search, you can turn up essentially infinity companies that would be happy to take your money in exchange for their stamp of approval. And they're not all good, right? Nor are they mostly good. Only a handful are genuinely reputable. And among those few in the handful, like ACSM or the NSCA's CSCS certification, those are very, very reputable, but the vast majority aren't. So we're going to go through an article now by Peg Chigalella. She's the one in the picture here. She's a first author. She's a physiologist and an attorney, and so she's uniquely positioned to write articles like this. And here she takes a close look at one such quote company. Right, again, that's kind of a euphemism. Company is kind of a euphemism for the business practices of many of these. But this will help us understand what personal training certifications are and what purpose they're meant to serve, and sometimes where they fail to serve those purposes. So I'm going to read the introduction here, just word for word. In 2002, an overweight, sedentary, and middle-aged man suffered a heart attack during his first workout with his certified personal trainer. During the workout, the man repeatedly asked to stop because he was experiencing fatigue, heat, thirst, breathlessness, and chest pain. The trainer responded to requests to stop and complaints of fatigue by questioning his client's masculinity and by continuing the workout. Now, this is that in the first slide where I said I was going to hint at appropriate correspondence, appropriate interactions with a patient or a client or a subject. This is that. And if you pull up the article and want to read it yourself, you'll find exact quotations that were reported in court that are that the trainer said to his client, we're talking about questioning his masculinity, that are somewhere between inappropriate and grossly sexist and otherwise disgusting. So it is important to have professionalism in our correspondence. Uh, Now, getting into the lawsuit itself, getting into the second paragraph here, there's some more summarizing information. The personal training client experienced a myocardial infarction at the end of the supervised exercise session. So he was supervised right into a heart attack. And the trainer knew his client was unfit to the extent that of his understanding of fitness, right, which probably wasn't very much. But he never invested, the personal trainer never investigated Rostai's risk, the client's risk. He didn't go through a health history with him, and he had never heard of cardiovascular risk factors. So Rostai didn't survive, or he did, I'm sorry. Rostai survived. And upon surviving, he sued the trainer, which seems reasonable. Some of those details are in the upper paragraph. And then the trainer was certified through the AMFPT. Some of those details are in the second paragraph, but I'll just read this part. If you have exercise and experience with dieting yourself, you may have the ability to be a good fitness trainer. Now, I went to the website myself and verified that exact quotation, and it was there. And that's the equivalent of saying, if you've eaten food, you may have the ability to be a good chef. Right? Or if you've driven a car, you should be an executive at GM. Participation and knowledge are two totally different things. And it's dangerous to conflate them, especially when working with bodies. And then in the last paragraph here, it's just worth noting that cosmetology and massage therapy have licenses. They have government regulation that oversees a standard of care, but personal training does not. And then at the end of this lecture, I'll tell you how the case ended. But before then, let's move on to what the risk factors are for an adverse cardiovascular event for something that happened to Rostai. Can we predict this? Are we able to estimate risk before working with the clients? And the answer is yes, we're pretty good at it. We're not perfect, but we're pretty good at it. And a very simple risk analysis is the PAR-Q. This is two different looks. It's the same questionnaire, but formatted differently here. And this is it's a physical activity readiness questionnaire. And it's simple. It's questions like, do you feel pain in your chest during activity? Do you have pain in your chest while not performing activity? Do you get dizzy and lose your balance as your doctor told you not to exert yourself? These questions are aimed at ruling out the big cases. They detect the obvious ones. But there's not a lot of subtlety here. I mean, the big exclusions, that's necessary. That's critical. But in some cases, it's insufficient. We need a little bit more. And to get into that little bit more, we have ACSM's Guidelines for Exercise Testing and Prescription. This is the book for our field. If there's a single book in our field, there's a million, but if there's one, it's this. And on the screen right now, that's the ninth edition. It came out in January 2013. It's a little bit old, but it has a really nice chapter two, which is where you find the primary health screening information and the list of variables that we would regard as potential risk factors. So that's age, it's family history, cigarette smoking, a sedentary lifestyle, obesity, hypertension, dyslipidemia, right, poor cholesterol, and diabetes or elevated blood glucose levels, fasted blood glucose levels. There's also a negative risk factor they note, which is high HDLs. If you do a lipid screening, your total cholesterol might be 200, but if your HDLs comprise half the total, that's not risky. That's certainly less risky. Now, you don't need to know every single cutoff. The exact values that are considered risk. What you need to know is the categories. Advanced age can put us at an elevated risk. How advanced of an age? You can look that up later. A sedentary lifestyle predisposes you to poorer heart health. How much activity do you need? Look that up later. High LDLs are risky, and If you don't know your lipoprotein breakdown, then high total cholesterol is considered risky. How high does it have to be to have a risk cutoff? Again, you can look that up later. The generalities are what you need to know. And among those generalities, notice there are some missing variables here, like diet. Nowhere in here is diet represented, or emotional stress and trauma. Those things aren't represented either. And cigarettes are listed, but alcohol, cocaine, and other drugs, those are nowhere to be found. So this isn't a complete list of all risks, but it's a pretty good one. And it does change from year to year. Certainly, how we look at these things, not just the cutoffs, but how we evaluate risk changes from year to year. And this is the 11th edition. What we were looking at previously was the ninth edition. This is the 11th edition of the same book, came out in 2022. And it's structured in the same way, in that chapter two is all about pre exercise screening. That's the same topic as the previous chapter two. But table 2.2 is different in this one. It's not necessarily things you can screen for in a casual setting, like left ventricular ejection fraction. How do you screen for that just at the gym, or over the phone, right? Or rhythm problems in the heart, tachycardia, stuff like that. These are hard to get outside of a clinical setting. Now, the patient might know it, they might have clinical data, but they might not have it either. And you can't just look at their heart and on the outside, over the shirt, and just it looks pretty good. But there are some questions that can be asked and should be asked, and some things to really look out for. And again, this is the 11th edition, the major points that it draws attention to. And so the first one would be pain that we would associate with myocardial ischemia, meaning restriction of blood flow to the heart muscle, specifically in this case. Um, be on the lookout for that. These are big picture, PAR-Q like kinds of signs and symptoms that you really have to survey. The second one is shortness of breath. That's another major sign that something risky might be afoot. Dizziness, that's another one, or in more extreme cases, syncope, which means losing consciousness. So either dizziness, we could put some balance problems in here. We could lump into dizziness, or fainting, whatever you want to call it, passing out, whatever the colloquial terms are. Pnea problems, right? P-N-E-A. It just means breathing. So fill in the blank pnea, like apnea or dyspnea. Dyspnea means trouble breathing. So this is something to be aware of. Ankle edema, that's swelling in the ankles. I mean, if it's like a healthy soccer player who has a recent sprain, we can look past that. But otherwise, if it's in somebody who exhibits some risk factors and doesn't have an ankle sprain, this can indicate heart failure. And really just at least glance at the person's ankles and try to see for this one, in addition to asking questions. Cardiac rhythm problems is another one. So palpitations or tachycardia. So palpitations, unusually hard, sort of beating, or the fast beat, tachycardia, the fast beating of the heart. It could be bradycardia, that's a slow pulse, but rhythm problems in general are something to be aware of, to look out for. And then intermittent claudication. This means leg pain that you would feel during exertion, during exercise, owing to insufficient blood supply. So after ceasing activity, it should go away kind of quickly, but it reliably returns as you begin exercise again, probably from accumulated atherosclerosis from plaque, but leg pain with activity. And a heart murmur. This is sounds that you can hear on a stethoscope, swooshing and other noises that you wouldn't expect to hear. It doesn't necessarily mean anything dangerous, but it can, and so it's good to know. And then the last one is unexpected Fatigue and exhaustion, this often accompanies a shortness of breath. We talked about apnea, we talked about breathing problems earlier, but that often arises here too. But what we're really looking for is uncharacteristic fatigue from what you would normally expect given this particular level of exertion, the present state of mild activity, and you're feeling a little bit additionally fatigued. So those are the major things to look out for, the big risks to look out for. Now, what do we do with these patients or subjects or clients? I mean, it depends if they exercise regularly already. If they're already participating in regular exercise, and there's no history of diagnosis or signs or symptoms of disease that you're seeing, cardiovascular, metabolic, or renal disease that you're seeing, just get on with your life. Exercise vigorously. Whatever you feel up to doing, go do that. But if there is a disease state in a regular exerciser, somebody who has consistent exercise patterns, then moderate intensity is about as high as you want to go. That's okay to continue, but to do anything more vigorous than that, you want to get medical clearance first. And if you're seeing signs and symptoms presently, that list of risks we just finished going over, if you're seeing that stuff, just stop exercising and get medical clearance, or have your patient or your client stop exerting themselves and get to the clinic for a checkup. For people who don't participate in regular exercise, if there's no known disease or symptom of any kind, you don't need medical clearance for light or moderate intensity exercise. And just be gradual in a transition to intense activity. Don't leap into it. Just life should be long. And so let's transition into this gradually. But for everyone else, get medical clearance. That's the rule. So now here are some case studies. Just reflect on what you've learned so far from the ninth and 11th editions of ACSM's guidelines and try to extract as much relevant information as you can from these cases. I'll let you read them. Just pause the video, take your time, and think about whether these subjects, these patients, clients, whether they participate in exercise, how much exercise, are there known cardiovascular, metabolic, or renal diseases here? Are there signs or symptoms that would suggest disease? Are they expecting to do anything vigorous with their lives? Think about these questions, and then any other information you can get, age and smoking status, and the other minor risks that we went over in the ninth edition of the guidelines. And then here's case study 2. Think about the exact same questions. Try to identify as much relevant information as you can about this 22-year-old woman's risk. Here's case study number 3, same instructions. Case study number 4, pause and enact the same instructions with this one. And case study number 5, this is the last one, same thing. Try to figure out as much relevant information as you can and ignore the irrelevant stuff. But take note of maybe there is a relevant point being hinted at in the irrelevant details. So, wrapping things up, the number of people who recommend and prescribe exercise, write out programs and prescribe exercise is high. It is a huge number. And it doesn't matter whether this particular statistic is exact, even if it's like close to accurate. If it misses the mark by half, that's still an enormous amount of people who are responsible for the bodies of others, who are prescribing and suggesting, recommending exercise, and they aren't licensed. Unless it's like a physical therapist or a physician or someone like this, they aren't licensed. There's no government agency overseeing the quality or safety of that practice. And it's important to remember that a certification is not a license. A certification, no matter how good it is, ACSM, CSCS, the best ones, these still aren't licenses. And plenty of other industries are managed by government oversight to protect the consumer, like barbering and cosmetology. These are licensed, but personal training is not one of them. Okay, so this is where we're going to end with how the case resolved. Who won, the trainer or the client? The answer, the trainer won. And I'm going to end, and it's weird that it ended this way, but I'm going to end this lecture with a reading of Peg Cicolella's concluding remarks because it really summarizes the important points. It is possible that Rosti meaning this case, the court, that Rosti reached its conclusions based upon inadequate or unpersuasive evidence. The court's failure to recognize the most rudimentary principles of exercise as medicine is stunning to the professional exercise physiologist. The court erroneously concluded that vigorous exercise is necessary to achieve fitness, failed to properly distinguish skeletal and cardiac muscle, expressed a decided lack of understanding of overload or minimal thresholds to achieve a training effect, inappropriately defined the purpose of training, and failed to acknowledge disparate risks of exercise in the young versus middle-aged. Misunderstanding on these issues is at odds with protection of public health. Resolution is as much an educational as a legal issue, and it is incumbent upon the profession of exercise physiology to dedicate resources to the implementation of a strategy that will offer a remedy. Until that time, the public will remain at risk when trainers have no standard of care to which they are legally obligated. And that's where we'll end lecture 1. I will see you in lecture 2.